Good evening, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Corinne, and I will be your moderator. We are excited to welcome Dr. Marc Geissberger as he will be reviewing techniques and materials that will streamline the Class 2 restoration. Before we get started, we do have a few reminders for you. At any point during the webinar, if you have questions, please type them into the Q&A section of your control panel, and we will answer them live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand, and this webinar is sponsored by Clinician's Choice. Dr. Geissberger, welcome, and thank you for being with us tonight.
Thanks, Corinne. Happy to be here. Well, I'd like to thank everybody for joining us this evening, and I'll get rolling. So tonight's going to be an opportunity for me to share with you some of my thoughts on Class 2 restorations and navigate you through a process of doing these to what I consider a high level. On your screen is an image of a Class 2 restoration, a DO on that upper first molar. And my goal here is to show you how to make these truly disappear in the oral cavity. So I want to thank everybody for joining us and participating in our program. So with that said, I'd like to give you a little information about myself. I graduated in 1991 and immediately returned to faculty at the University of Pacific School of Dentistry in San Francisco, where I taught full-time until 2018. In 2018, I became an adjunct clinical professor and have held that position until recently when I fully retired from the university. Currently, I occupy my time in private practice with my brother and formerly with my dad, who's passed. And I'm in full-time practice and then lecturing and teaching dentists how to do things. In addition to that, I work with a lot of product evaluation with industry leaders and helping them bring new concepts and materials to markets. I work with a group out of Chicago called Catapult Education, founded by Lou Graham. And I have a family, a wife and 3 kids. In my spare time, I restore cars rather than restore teeth. So I guess I'm pretty much full-time restoration of something. With that said, I'd like to thank Henry Schein for having me on their platform and Clinician's Choice for their sponsorship of this program this evening. So let's get started. And I want to talk a little bit about Class 2 restorations. Now, if after this evening I've whet your appetite to learn more about how to do these, I encourage you to join us for one of Clinician's Choice programs called Hands Online Live. And you'll see that logo on the screen throughout this evening. I teach a Class 2 restoration program in the comfort of your own office. We'll send you the kit and do that. Now, our next one is in June 28th. So if you're interested after tonight, let us know. All right, so first and foremost, I graduated in a time where we did Class 2 composites so rarely that we really tried to use amalgam equipment to do them. And what you see here is an x-ray of 2 restorations I placed. Now, first of all, they're both sealed cervically, which is a good thing, but the top one was done with a Toffelmeyer using very old techniques, and the bottom one with a proper placement and use of a sectional matrix system. So we'll go over those this evening as we go through the program. Now, what I see too often is this type of dentistry. This type of dentistry leaves a lot to be desired, but if you look, there have been Class 2s done on the lower molar, lower first molar, and upper second molar. And when I look at that upper second molar, I notice that ding in the adjacent tooth. Now that is not incipient caries, but rather iatrogenic damage to the adjacent tooth while preparing that MO on the upper second molar. You'll also notice that the teeth have grossly been over-contoured cervically, and they actually lack a proximal contact in an ideal situation. So whichever practitioner did these restorations likely did everything wrong, from sectional matrix placement to restoration placement to protection of adjacent teeth. And it saddens me to see this in my practice on a fairly routine basis. I'll show you another clinical case Where things appear a little better on this upper second molar from a bite wing standpoint. But if you notice in the PA, you can see an overhang of restorative material and no proximal contact. And that happens routinely. So this restoration I had to take out. Not only that, there was recurrent caries under the restoration. Now, sadly to say, this restoration was only about 6 months old. So here's the clinical case. And you can see that second molar. You can see the stain showing through. This happens to have been done with Omicron. Now I've omnichroma, excuse me. And I've heard people say that it matches everything. My clinical experience tells me that is not the case. And when you look at these two restorations done with omnichroma, they are painfully obvious. Not only that, the material is so translucent, you can see what's going on underneath. Now, there is no proximal contact here. And in this case, I placed an inner guard to protect the adjacent teeth, and we'll talk a little bit about how to do that. And then we've removed the restoration, and you can see decay present under that restoration. Get the decay out. Now we've got only stained, unaffected dentin and a clean cavo surface. I then pop in a sectional matrix. In this case, I used a product called Triodent. And I'm going to go over Triodent and another great product that I use routinely called Dual Force from Clinician's Choice. And I'll contrast those two for you just a bit and tell you the pros and cons. I restored that completely with Composite, finished it back, got all of my excess, and now we have a reasonable restoration with a tight proximal contact. That blends in much better than the omnichroma ever did. Now, with that said, I want to show you another class 2 utilizing Evanes from Clinician's Choice and a sectional matrix system. Now, again, I use this product to protect adjacent teeth. In fact, I do that each and every time. You can do this with something called an inner guard that's from Ultradent, or you can do it with something from, say, Paladent called the Wedge Wand. Those both work beautifully for this. But what I do is I drop into the decay, and now I won't damage the adjacent teeth. I also want you to notice how dry the tissue appears out there on the buccal. That's because I use an isolite for all posterior restorations, and that keeps the field dry, free of debris, and will not affect my final bond. So I go through and place my matrix system. Now, this is the original matrix band from Clinician's Choice dual system. But what I want to point out here is you can see how wide open that appears. It doesn't look like the letter C. So they've really dramatically improved this matrix band by getting it to hug the tooth more substantially in its second iteration, which is now available, and I'll show you this evening. So I've got my wedge in place, and then I put on my dual ring here. So this dual force ring exerts a lot of pressure between the teeth, separating those teeth and allowing me to get a nice tight contact. So in this case, I'm doing total etch, and I'll get into adhesives just a bit for these posterior restorations. After I've placed my adhesive and cured that, I'll do a little flowable composite in that box form, and then I'll go ahead and restore that with Evanes composite, light cure, contour, and polish. And my goal each and every time is when I'm done with the restoration and look at the final result after it's rehydrated, that I have, number one, an anatomically correct shaped tooth, and number two, a restoration that is virtually impossible to identify visually. Of course, you'll see it radiographically. So with that said, I want to review a few of the products that I use on a routine basis, and we're going to start with adhesive systems. Now, the reason I want to start with adhesive systems is really it is the core of what we do clinically. So with adhesive systems, it's really important to recognize that systems live in either the etch and rinse camp or the self-etch camp. And I'll go over these briefly with you. Now, as far as the 5th generation etch and rinse camp, these are a 2-step system that employs an etch and then a primer and adhesive that is combined into one. Now, there are many examples of these, and these are total etch, meaning you'd apply your etch on the entire surface of the tooth, regardless of whether it's dent and enamel. Rinse that off, place a primer, air thin, and light cure. So these two-step systems work very well and obtain a very high bond strength. One of the ones I use routinely in my practice is MPA Max from Clinician's Choice. This is a unique bonding agent for a number of reasons. First of all, it is a bonding agent that has a UDMA and proprietary monomer. It has an ethanol carrier. It is filled by about 7.5%, meaning it contains glass with a very high average bond strength to enamel. In addition to that, and two very important things is, number one, it contains 0.2% chlorhexidine. And the second, and very important, is that when we air thin this material, it air thins down to 2 microns. Now, why 2 microns? Well, the thinner you can get your adhesive layer, the higher your overall bond strength. So this material has a lot of benefits. Now, I want to mention all the products I've used in this category: MPA Max, Single Bond from 3M, PQ1 from Ultradent, and OptiBond Solo Plus from Kerr are 4 bonding agents in the 5th generation category that I think work extremely well and have a lot of efficacy. And I've used all of these. With that said, I know a lot of people have moved to what are called the self-etch adhesives, and I want to talk about those briefly. Now, one of the limitations of a self-etch adhesive is that we're not using phosphoric acid, but rather different acids to etch dentin. With that said, those different acids aren't very efficient at etching enamel. Now, for me, a class 2 restoration must have etched enamel. We must maintain its cavo surface integrity to ensure the longevity of the restoration. So if I were to employ a 6th generation adhesive for, say, a class 2 restoration, I wouldn't use it in its self-etching mode, but rather I'd use it in a selective etching format. So what does that mean? Well, that means this, and I'll use, say, XTR as an example. Extra or XTR from Kerr is a great self-etching adhesive. And it is really designed as a self-etcher. But if I have cavo surface on enamel, I'm going to go with what you see at the bottom of the screen here, and that's what's called a selective etch. What that means is I would place the etchant on the surface of the enamel only. Then I'd place the primer, the self-etching primer, on the dentin to etch the dentin differently than I etched the enamel. And then I'd take an adhesive and apply that to both of the etched surfaces. So this becomes a 3-step technique. Now, what does that do for timing? It adds about 20 seconds to the overall adhesive procedure, moving it from, say, 40 to 50 seconds to about 60 to 70 seconds. Is that a deal breaker? No. But most of the time, my default for posterior class 2s and class 1s is to still use a 5th generation 2-step technique using MPA Max. Now, with that said, in following the instructions with any adhesive is critical. You know, dentists are fairly free spirits, and what I've seen in so many of my hands-on courses that I teach is dentists like to experiment a bit with things. Well, let me just tell you this, that manufacturers work really hard to develop DFUs that provide optimum results, and their instructions really need to be followed to the letter of the law. So with that said, if you take XTR as an example, you need to scrub this as a self-etcher for 20 seconds. And that really increases your bond. So whatever the instructions are from whatever product you're using, I want to make sure that you understand the importance of following those instructions to the letter of the law. Now, I want to talk about the composite that I'll be using in my demonstration this evening from Clinician's Choice. I'll be using both a flowable and a conventional microhybrid composite. The first thing I'll use is conventional Evanes. Now this material is very interesting in that it's a highly filled composite, and as such, it provides very high strength, both flexural strength and compressive strength, very low wear characteristics, very high polishability, and very low volumetric shrinkage, all of which are beneficial. Now, the one thing most clinicians notice when they use Evanes for the first time, being so highly filled, is that it tends to be a bit rigid or stiffer. Now, the way Clinicians' Choice has gotten around that is they actually make one that's a little more creamy in consistency, and that is called Evanes UX. That UX allows it to be a little softer in handling. So for those of you who try this, say, you know, it's too stiff, I'd like the UX, you'll find that that's viscosity is a bit lower. Well, both of these have a radio-opacity around 250. They come in varying translucencies, all the way from an enamel to a dentin, and the enamel can be as low as 50% translucent, whereas the dentin is 90% opaque. So with that said, you have a lot of choices in material. Now tonight, I'll be using a dentin shade and an enamel shade. This composite works beautifully, especially for class 2s. Lots of shades available. In fact, in my office, we don't stack every one of these shades because that would be overwhelming. I have a select few shades in the enamel and dentin shades that I use very routinely. So I'll also be highlighting Evanes Flowable. And Evanes Flowable is 62% filled, very high compressive strength, and a very easy product to use. And I'll be lining with that. Comes in multiple shades. And tonight I'll be using a universal shade for my flowable. I'll be using a 1 universal, and this is a great composite, also very radio opaque to be seen on an X-ray. Now, with that said, I want to show you what's important in selecting your materials, and that is that you have products that show up radiographically. So when you look at this radiograph in this upper second bicuspid, I'm going to replace that amalgam. And I did that using a composite that is highly radio opaque. Now you can see how ideal the contours are. You can see the curvature on the marginal ridge. You can see that I'm sealed cervically, and that this restoration, although it contained a flowable and capping composite, looks homogeneous. And that's because the radio opacities, the two materials, were quite close. Now, when you look at this, this is just using premise as a control, but you look at A through H being different flowables and realize that the radio opacity of the composite changes from company to company. So you want to know your radio opacity figures. You want to make sure that you're not putting a flowable that's so radiolucent that it may show up as caries in your box form. And that can really complicate things clinically. So that's important to recognize. Now, with that said, the radio opacities of flowable are all over the market, anywhere from kind of an average of 200 up to as high as, say, 320 on radio opacity figures. The first case I showed you actually used a very radio opaque flowable. That was about the only thing they did right. They had all those overhangs and open margins and you name it, it was there, but they used a very radio opaque flowable, probably SRO from Danville. Now, what I want you to recognize is that the Evanes flowable right around 200 to 225 is going to provide adequate radio opacity. You want to stay away from anything that approaches about 180 on the aluminum scale, because that starts to look a little translucent on a radiograph and not so opaque. So the higher the radio opacity figure, the better off you are, generally speaking. Now, remember I mentioned that our composite was quite stiff. I actually use the traditional Evanes, not the UX, but the traditional Evanes, and I use a composite warmer. So one of the things that product that I use routinely is from Adhesive called the calcic composite warmer. In fact, it's sitting right here next to me, ready to go. It's heating my composite so that I got nice, creamy consistency. Now, interesting thing about heating composite through this, and this is the system I have, is that when you heat composite, you actually drive up polymerization, meaning a composite that's been heated has been shown to be more polymerized and a greater depth of cure. So this is very interesting. Castro and El Karashi in 2 separate studies compared room temperature composite to heated composite and showed that there was greater monomer conversion and greater depth of cure in a heated composite. So that was a benefit. In addition to that, Carlos Munoz at University of Buffalo showed that when you preheat a composite to 155 degrees, regardless of whether it was a hybrid or microhybrid, you increase the depth of the surface hardness, which is essentially another way of saying depth of cure or completion of cure. Now, those articles and about, say, 60 others really support the fact that warming your composite not only makes it easier to handle, but produces a product that is more completely cured, harder on its surface, and has a greater depth of cure. Other studies showed that marginal leakage went down with warmed composite compared to conventional composite. Now, Daranch showed that you have to work efficiently. And what his study looked at is what happens if you dilly-dally around and you don't place your restoration quickly. Well, what he showed was that dilly-dallying around, if it took more than 2 minutes, you lost the heat of the composite and all of the benefits of increased curing, depth of cure, marginal adaptation, all of that actually went away. So what that means, and you'll see me tonight as I place my layers with a warm composite, I'm going to work very efficiently. And not a single layer should take me over 2 minutes. Otherwise, I've really lost the benefits for that layer. So I'm a big fan of composite warming, have been for a long, long period of time. I want to talk a little bit about some of the instrumentation I'll use tonight. The first instrument I'll use is from the Dr. Ronald Jordan composite instrument series. It's called the REJ number 10. And it is a great instrument for posterior and anterior restorations because I can cut off my composite and then place my composite with the same instrument and condense that. So I'll demonstrate that instrument from clinician's choice. In addition to that, I'm going to demonstrate the use of some contour finishing discs. These are aluminum oxide discs, one-sided cutters that help me contour at the line angles, both buccally and lingually, of all composite box forms, and really helps me get some really nice contours. Now, there are other discs I've used. The Kerr Opti discs are another one I've used routinely from Kerr, another good product for this. And I'm going to use what are called all surface access polishers from clinician's choice. If you haven't tried these and order nothing else after tonight's program, this is what you need to try. These polish composites like nothing you've ever seen. And I'm going to demonstrate those tonight. And I'll demonstrate the 2 types they have, but these are really brilliant polishers in a 2-step technique. The first step employs 44 micron polishing diamond particles, and then the second provides those 3 to 6 micron diamond polishers that really get a high luster on your composite. Not only that, they're designed to spare the anatomy you work so hard to create. So they really work well. Now, Clinician's Choice also makes one called an ASAP Daily, and these are designed to be used and autoclaved for a day only and thrown away at the end of the day. So if you're a practice that sees multiple composite patients throughout the day, this is a real great option for you. The first one is autoclavable that I showed you is autoclavable up to 30 times. Now, we're going to talk sectional matrix bands because this is really, really important and really establishes anatomy. There are lots of choices on the market, but the 2 that I use in clinical practice are number one, the dual force from clinician's choice, and the Paladent or V3 system from either Dentsply, available through Schein, or Ultradent. Now, the dual force has some unique characteristics, which I'll show you when we get to the live program. But their wedges are exceptional. I'm going to use that green one. That's the largest conventional wedge. But if you look right next door, there's a black wedge, and that black wedge actually has a little projection that is designed to help you seal furcations in upper first molars and say upper first bicuspids, that mesial invagination that's so troubling sometimes to seal. So this system works extremely well. Now, the Ultra Wrap band is different than the band I showed you at the beginning of the program, in that they've really been able to get this to hug the adjacent tooth, which works beautifully well. So I'm going to demonstrate that tonight. Well, I mentioned having some experience with the Triodent sold by Ultradent, or the Paladent sold by Dentsply through Schein. Now, this is a great system, and it works extremely well as well. These are the two I'd really recommend for clinical use. The band has a little curve at the top, very similar to the Ultra Wrap band that I'm going to demonstrate tonight, and some really adequate wedges that work well. Well, with that said, that's the end of my program as far as going through my slides. And I know I went through that quickly, but I want to provide you with my email address here following the completion of the live demonstration. And I'm going to take my time in demonstrating this and show you really how to place an awesome class too. But I want to encourage you to look up Hands Online Live and consider joining me on June 28th for a hands-on experience. And look at the other courses offered through Hands Online Live. Now, with that said, I've got to do a switch over to my camera. So give me just a second. Now would be a great time to have a sip of water if you've got that. I've got to pull over my loops and do a few things in preparation here. I'm going to put on my loops so I'm ready to go. And I'm going to go ahead and switch over to a new share here and bring up a live camera. So bear with me here. And I want to make sure that the people at Schein will confirm that that camera is live. Corinne,
looks good. Yep.
Excellent. I just wanted to make sure. And we'll be good to go. Now, I'm going to go ahead and get on some gloves, and we'll start this little demonstration. Now, I'm going to try and leave enough time with tonight's program to answer any questions. And I have seen on the question bar that we have a few forming. As you develop questions, please, please, please feel free to write those in the Q&A section, and I'll do my very best to get to them. Now, I'm going to zoom out here for just a minute and kind of just show you what's out and about on my tabletop. So bear with me because I've got a lot of stuff out here. Okay, I'm going to focus that for just a moment. And of course, I've got my patient right here that I'm going to work on. I've got my REJ number 10 from Clinician's Choice. This instrument contains a spatula on one end, and on the other end, my condenser, which is ideal for that. Now, in addition to that, I have a Pigtail Explorer, some micro brushes for the application of my MPA Max bonding agent. In addition to that, I have a product that I didn't mention in the lecture called Resin Blend. Now, Resin Blend is a liquid blending agent that works really well when you're trying to smooth off your anatomy and get that to go. In addition to that, I have my dual force ring on its forceps. I have Clinician's Choice little tweezers to help me pick up my, my sectional matrix band. And right in front of me, I have my green wedge right here. This wedge is going to be used to seal that cervical. And in addition to that, I have my Ultra Wrap sectional matrix system. Now, what I'm going to do is I'm going to lay this down, and I want you to see how tight that curvature is. And you'll see when I get that in the tooth, how tightly it holds the tooth. In addition to that, I have my curing light. This happens to be the Velo and I've got it set in the standard curing mode. In addition to that, I have my handpiece. This is a product I use from NSK. And right here off screen, but I'm going to pull it on screen for just a moment, is my composite warmer. And I've got the composite warming to 155 degrees. I've got my gun preloaded with the flowable composite Evanesce Flow. And the really cool thing about this is I can change the angle of the tip by 40 degrees. So if I want it real steep, I'll do that. If I want it flatter, I can do that. So I've got the flowable warming. In addition to that, I've got my compules of Evanesce A1 warming in the composite warmer. So I'm going to place that back and do that. Now, the first thing I've got to do to make this a go is put on my loops, and I'm going to zoom back in and refocus. So bear with me for just a second. Loops on. These loops are from Oroscopic. They are 4.8 power loops, extremely high power. I'm going to zoom in just a bit more. Now you'll see everything. How about that? And I love these composites. Now, on occasion, for me to be able to see, because I can't stand where the camera is standing, I'm going to angle this just a bit, okay? I also may flip it around, don't get dizzy, just to be able to see. So the first thing I'm going to do is flip this back around and get myself centered. And I'm going to come in here and I'm going to use my handpiece with a 330 burr to place a little bevel along my cable surface margin. So this bevel will increase the surface area to bond to. In addition to that, and I'm going to lean it back so I can see it again, Swanson showed that you get less marginal leakage with using a bevel. Okay, with that said, I'm going to return that to center. I'm going to go over here and grab a little air, and I'm going to just express a little air to clean up my preparation there. Okay, with that said, I'm now ready to get ready to place my sectional matrix band. Now, I want to go over some of the critical features in placing a matrix system. The first is height selection. Now, most matrix bands come in a variety of heights, and I am going to place my band in the mesial here. Bear with me for just a second. If my finger blocks your view, I apologize. I'm going to angle that just a bit and slide that in there and get that going. There we go. Now, what I want to make sure is that this band is, number one, centered mesiodistally. So I want that centered. I want the band at a height so that the curvature that is presented in these bands, and I'm going to point that out to you, there's a little curvature at the top of this band right here, and that curvature provides us our marginal ridge. Now, what you can see is cervically I'm open. So I'm going to come in here now with my wedge. I'm going to wedge this, and I'm going to compress that against the gingival aspect of this typonome. Now, with that said, I generally will try and hold my wedge or hold the tooth in place as I place the wedge. Now, what you can see is I've sealed the cervical, and I'm going to hold that in place until I place my clamp. Okay, so I've got that in place. We're good to go. Now, one little trick in placing clamps is to get in the habit of trying to hold down your matrix band. So I open this really wide, okay, very wide. I slide in from the mesial, and before I let go, I put my finger on top of the entire system so that the matrix band doesn't shift. Now, when we look at this, you can see I'm sealed cervically. What you were seeing before is just a little shadow there. I've got that all the way sealed. I've got my dual force in place, and I'm going to turn this on its side to show you one other aspect, And that is the angle you'll see. Now, I'm going to lay this right here. And I want to tell you about what angle I'm talking about. When you use the clinician's choice dual force, it's a little different than other systems in that most matrix band or clamps will sit parallel to the occlusal table. This one is set at about 20 degrees. Now you ask, why would that be set 20 degrees? Well, the reason being is this was designed to be able to fit over rubber dam clamps. So let's just say you're working on a DO on number 30 and you've got a clamp on 31 and you want to put in a sexual matrix system, but the clamp's in the way. Well, this angle will prevent that clamp from interfering with your setup. So it works extremely well. And again, I want to roll this to the side so you can see that we're sealed there. What you're seeing is a little shadow from the camera, but we're perfectly sealed gingerly. Okay, next thing is to place my adhesive. Now, because I'm in my office and I'm not right by the sink, I don't have the ability to rinse everything off. So I'm going to omit the etching and go right to my adhesive placement. Now, one thing with MPA Max or any filled adhesive is before dispensing, you want to get in the habit of shaking the bottle, even tapping it on the table to allow the glass to get mixed evenly throughout the adhesive is very important. Because what will happen is that glass can precipitate out of your bonding agent just by sitting. So I've got my bonding agent dispensed. I would have total etched the entire surface. Now I'm going to come in here and place my adhesive layer. And I'm going to scrub that. I want this infused. And as I do this, I generally re-dip, okay? So I'll re-dip here and go ahead and reapply. And now I'm going to air thin, and you really want to get this thin down to that 2 microns. How do we do that? We do that with about a 5-second air blast. So what I'm going to do is I'm going to hold this clinically right above. And we want to move our air throughout the preparation. We don't want any cooling. You also want to make sure that you get it on your matrix band to get that all cleared out. And when this is done, it should resemble kind of a cellophane look. Now, I've got this set for 20 seconds in the standard curing mode. I'm going to bring that right over my tooth and go ahead and cure for that 20 seconds. This light is going to beep at me every 5 seconds just to give me a heads up. And I'm going to go ahead and let that cure for a full 20 seconds. Why? I want my adhesive layer fully cured. And I'm going to now switch my light to a 10-second mode because I'm going to layer this. And the first layer I'm going to place is going to be my flowable composite. Now, again, I've got to angle this just a bit, and I'm going to demonstrate placing that flowable. And we're going to place that right up against the box. Now I'm going to go around and place that at my line angles. Now, with that in place, I like to use an explorer tip to move this flowable around. Now, with Evanescent flowable, it really responds well to being moved in various aspects of the preparation. So I'm going to rotate this just a bit, get down here into the box form, really pull that into each of the line angles as we go through this. You can see me adapting it now to all of the cervical area. And when you do this, you want to make sure that really everything underneath is fairly smooth. So that explorer tip and that warm flowable work so nicely. And you can see how well that's adapted. Now, I want to point out one thing. See on the distal right here, I'm a little irregular. If I see that, I just go in and smooth that. Having a nice smooth base of flowable helps to seal your margins beautifully and really allows you to place your next layer quite efficiently. Now I'm going to grab my curing light and I'm going to go ahead and cure this. And I'm going to give that a full 10-second cure. So with that said, I'm going to switch out my composite gun. And I want you to know that in clinical practice, my dental assistant does all of the curing. I don't. And she's been trained really well to know right where to put the light to make this efficient. But with that said, I'm my own curer tonight because she's not sticking around past 5 o'clock, and I don't blame her. She's got kids and a family to get home to. So I'm on my own tonight. So I'm going to be my own dental assistant. Now, what I'm doing, and I'm going to zoom out for just a minute because I want to demonstrate this to you. So you understand my workflow and practice. So what I'm going to do is zoom back out just a bit. I'll refocus for you all once I get this in here. Now, I've got my composite gun, and we're going to focus that. Hopefully it'll focus on me. There we go. And I've got my Evanescence composite. Now, while my assistant is curing the flowable, I actually am doing something behind the scenes. And what I do clinically is I cut off the next layer of material I want to place. Now, this happens to be the A1 Evanescence Universal, A1 Universal, and I cut off the amount of composite I want to place while she's curing. Now I'm going to zoom back in. And the reason I do that is, remember, I have that 2-minute window to place composite. So now what I do is I come into the box form and I just lay that down in there. Now, and then we start condensing that. Now, I'm going to dispense a little bit of my resin blend, and I want to work efficiently, even though I'm talking you through this whole procedure. Get a little bit of the resin blend on the end of my instrument to help me place. I'm going to angle this ever so slightly, and now what we're going to do is compress this into place. Now, the REJ is a great instrument to do this. It's round at the tip. And what I want you to appreciate is that I'm using what's called a tap and burnish motion. So you can see how well that adapts into there. And I'm using that tap and burnish motion to get my box form complete. So nice and smooth, that resin blend worked beautifully well. Now what we're going to do is, my assistant knows that as soon as my finger leaves the patient's tooth, that she is in there shining with a light. While she's shining with a light, I'm cutting off the next composite that I'll place. I'm going to cure for 10 seconds and then cut off that composite. Okay, so you can put a clock on it, and you'll see that I really don't spend an extraordinary amount of time in placing the next layer because I'm incrementally layering this. I'm going to cut off my composite. So I express that composite. Now this would have already been done. I cut off what I want, and I'm going to layer the next layer right along the occlusal portion of the tooth. Now, you're probably asking yourself, why didn't I go right back into the box form? And that's a very valid question. And there's I think, what I consider a very valid reason for not doing that. And that's because I want that box form to get more light. Now, if I covered over it with another layer of composite, I'm robbing the box form, which is the deepest part of the preparation, of additional light. So if you notice, I've gone to the occlusal, I'm not filling anywhere near the occlusal. And now I'm burnishing that. And I want this layer to be super smooth to accept the next layer. So take a look how smooth that is. Now, people ask all the time, I get voids in incremental layers. I said, here's what happens. You get voids because you're probably over manipulating the material, or you're not burnishing it as you go. You may want to employ the use of a resin blend from Clinician's Choice. I've got that at the end of the instrument, which smooths this off super, super nicely. So I'm giving that 10-second cure. And as soon as that goes off, now I'm going to go back to the box form. Okay, so all cured. And I'm going to grab my next layer. I'm going to express what I want to place in the box form, cut that off, put my composite immediately back into the warmer, come to the patient and lay this down. Now that time, if you notice, I laid it on its side, and I'm going to try and drop this right into the box. Ooh, I forgot my resin blend, therefore it sticks. So let's get that back in there. And there we go. Now my resin blend allows me to just do my burnish, and that burnishing and kind of smoothing off of the composite will really help blend the material. So I want you to notice that each layer I'm placing is nice and smooth. Okay, with that done, remember I want to cure in under 2 minutes. Got to get that layer placed in under 2 minutes. I get that cured. Now the next thing I'm going to do is place another layer along the occlusal and get myself ready for the anatomy. Okay. So the tooth I'm demonstrating on is probably the largest composite you'd ever place without doing a crown. It is just a huge restoration. But this huge restoration allows me to demonstrate various aspects of doing this. Now I'm going to condense this, and I want to leave it deep enough so I can form a central fossa. Now I'm beveling that towards the mesial. I dip my instrument in resin blend. Now I'm going to basically start feathering this composite. And I want this layer to be a nice, smooth layer to accept my next layer. So if you notice, I spent a little time burnishing this, and this is what prevents voids. And it really helps eliminate those. So now what I'm going to do, that's nice and smooth, I'm going to cure that again. So that's going to be a 10-second cure. If I were sitting in my chair, I would be cutting off the composite right now, but I don't have that luxury this evening. So I'm going to cure that. Okay, now what I'm going to do is grab my composite, and I'm going to cut this final layer. And this box form was 6 millimeters deep. It was a deep one. I'm going to cut my final layer. And if you notice, I just laid that right in for the marginal ridge. I'm going to lay that in. And now I'm going to use the spatula side to start kind of condensing that up against the marginal ridge. I'll use this spatula to help me kind of clear excess, try and minimize the amount of excess on, and I'm filling right to the height of that matrix band. Now what I'll do is I'll lay this on its side and just condense that just a bit. I'll thin out my marginal ridge by using the instrument and pulling some of that composite down to give me that correct marginal ridge height. So I'm just beveling forcing that material into my bevels. And now I've got my marginal ridge placed to the height. If I notice anything, again, I'll bevel out to where I want the material. Get that leaning to provide a marginal ridge. And now we like here. Okay, now I'm going to leave intentionally just a little flash so you can see how I finish that back if you accidentally put a little there. I did that intentionally so I can show you how to do that. Now what I'm going to do is I'm going to go ahead and place another. I'm going to start with my occlusal anatomy. Now this is really cool. You can do it in many different ways. This is where I told you I'd be flipping this around. But I'm going to start with one of my lingual triangular ridges. And I actually build my triangular ridges in really 4 or 5 steps, depending on the anatomy of the tooth. And if you notice, I cut off a small piece of composite right here for my distal lingual triangular ridge. And no mirror trickery here. I'm just beveling into the occlusal. I'm trying to maintain this nice straight line here on towards the lingual groove so that we can have a distinct lingual groove. And I want to make sure that my composite doesn't cross onto the anatomy of the buccal. Okay, so I'm really trying to establish that nice groove. Now I use the side of the instrument to get me my heights. Now what I'm going to do is take my Explorer. Remember the instrument I told you, this is one other instrument I use. I'll lay my Explorer right here to give me my triangular ridge anatomy right there. And in short order, we've got our first triangular ridge. Okay, now, again, my assistant's curing. In this case, she can turn the curing, and I'm going to do that to 5 seconds. Why? Because now I'm placing these individually. So I'm going to go on to the next one. I have then 5 seconds to cut my next amount of composite while she's curing. I would have already been done and standing by. I would have immediately re-entered the mouth with my next layer. Again, I'll dip my instrument in a small amount of resin blend. I need a ton of this. And I start burnishing now the mesiolingual cusp. So I place this here. I'm getting my anatomy in such a way that we're going to have a nice space for my distal or my mesial buccal cusp. I've got my anatomy placed there. If you notice, if you do this correctly, you'll have that nice lingual groove. And it'll be formed for you. So we place that. Then what I'm going to do is take my Explorer tip, come in here, form a mesial fossa, reestablish my lingual groove. There. Make sure I got a nice defined mesial fossa. And then we'll like here. Okay, I'm getting this done for you. 5 seconds. Why? Because I'm moving on. I'm not putting composite now on top of itself. I'm putting it next to itself. So now if you think about it, that distal lingual cusp just got another 5 seconds of curing. I come in here now on my mesial buccal, place my composite. And when you first start doing this and practicing, likelihood is you're going to overfill certain areas. You're going to take too much composite into certain areas. And if that happens, it's not the end of the world like I just did there. I can just pull that off. And now I'm going to taper that composite in there. I'm going to leave that nice mesial fossa. Now what I can do is redefine my central groove coming through there. Okay, just using Explorer tip, no fancy instruments here. Get my anatomy set, triangular ridge set. And I love that we got a buccal groove there. Now we're going to light cure 5 seconds. Now, when you think about it, I cure for 5 seconds. The mesiolingual cusp just got its 10 seconds. And now I'm going to come back and do the distal buccal. I'm going to cut off a small amount of composite for that. Place this into place. And I have even room for my distal cusp. I'm getting fancy here on this one, you guys. I'm sorry, but it's what it is. So remember, my goal is to make a tooth look like a human tooth, not a blob of composite. What I showed you earlier, my nice way and what I tell patients is those restorations were uninspired anatomically. That's a polite way of saying they're not really nice. Come in here, get my groove. Come in here and get my triangular ridge grooves. And there we go. There we go, bevel that just a bit. I love using this. And now you can see, oh my gosh, look at that, triangular ridges. And it's not one big flat bowl. So I haven't cured yet, but I'm trying to show you that this is all done very quickly. Now I want to cure to maximize that conversion of composite. And I have one bit of composite left to place on this restoration. So we'll be done here in just a minute. Okay, so I'm going to place that now, and it's a tiny amount. I'm going to remove my matrix band and show you what we got. Okay, so we're doing super, super well. Now it's a little tiny distal cusp. Doesn't need a lot composite. Got that all filled. Come in here, get my anatomy. Now this one I need to up to 10 seconds because I'm done. So I don't want to cure this one for 5 seconds. And my assistant will hear from me, hey, this is our last layer. Go ahead and get that cured for 10. And she does it. Now, curing for 10 implies that I have a functioning LED light emitting at least 800 nanometers of energy in the right wavelength. So I encourage you all to test your lights. Now, with that said, I'm going to pop this off. I'm going to pull out our wedge, and I'm going to grab my little tweezers. And one sign you know you've got contact is if it's a little struggle to take out, okay? So the next thing we're going to do is just show you. Now, I intentionally, remember I said I'm going to leave a little flash. If you notice there's a little flash, I did that intentionally so I can show you how to remove that very quickly. We then adjust the occlusion and polish it. So I'm going to come in here, and I've got the disc facing away from me. So I'm going to come in here and very quickly, I just round this over. And I can come out to the facial and get that rounded. Now, if you have a little flash anywhere else, I'm going to slow it down, nice stall speeds. Now we've got a marginal ridge that's curved. You can see 3 fossa in that image, mesial, distal, and central. The last step would be to simply polish this with our ASAP polishers from Clinician's Choice. So I'm going to give you a quick little polish. And while we're doing that, Corinne, if you have any questions, feel free to read me a question because I can answer those. I know we've only got a few minutes. And I just
Sure.
But why don't I answer a few if you've got any? I'll try and multitask for you.
Great. Yeah, we have a bunch.
A bunch, oh no.
One of our questions is, how long do you schedule patients for a class 2 like this, and also for multiple class 2s?
Okay, so great question. I usually schedule patients 45 minutes for class 2. 2 class 2s would be about an hour and 15 if they're side by side. And you know, I'm pretty efficient. I spend a lot less time prepping because I use that interguard, and a lot more time actually placing the restoration, but no more time than I think most clinicians would spend doing this. So that's about the timing. Okay, so now what I want to do is just, okay, so what I'm going to do now is just roll this around, and you can see that we've got, now this is the most important, right there. Can you see that I've maintained the anatomy with those polishers? There's a good example of that high luster coming off that triangular ridge. So with that said, that's it for tonight, but I'm going to continue answering a few questions because I've got a couple minutes. So keep going, Grant.
All right. Our next question reads, any concerns about the shrinkage of the flowable in the proximal box?
You know, that's a great question. And there have been about 6 different studies that looked at the performance of a flowable compared to a conventional composite, and actually showed, oddly enough, that even though flowables do shrink some, that there was less micro leakage at the cervical when you compare a flowable to a conventional composite alone. So I have no concerns, and I've been using flowable in the box form for about 12 years with super high clinical results.
Great, thank you. Our next question reads, I noticed you didn't use the composite gum directly into the box prep, and you administered the packable composite with your instrument. Is there a reason why you did it this way?
Yes, that's a great question. I love that question. It actually gets down to being precise. When you squirt composite into a box form and somehow kind of tear it off, you run the risk of creating little shards on that composite. And that's what I think leads to a lot of voids in the composite. The other thing is, if I'm going to wait till the end to place it, I've got to be standing by with my composite gun and then waste time. So by using the time my assistant is curing it to come in here while she's curing, express exactly what I think I need, cutting it off allows me to place precisely the amount of composite, precisely where I want it, without incorporating any voids. And I think that really helps with the overall clinical results.
All right, thank you.
Thank you.
Our next question reads, do you ever push the flowable into place with the packable composite to avoid voids?
You know, I've heard of that technique, And I don't think there's anything wrong with that technique. It's not something that I do. But it's fine. If you were to place the flowable and then pat the composite, no problem. I don't see any real problems with doing it. It's not something I do, but I don't think you'd be wrong in doing it.
Okay.
Yeah.
And another question from the same person just was wondering why you cured the bonding agent for 20 seconds and the flowable base for 10 seconds. Can you explain the reasoning behind that?
Yeah. So for me, the bonding agent is the most critical aspect of our restoration. It's what seals the dentin. It's what provides us no micro leakage. And I always want to make sure that that being the absolute deepest gets the most amount of curing. Now you could do it for 10 seconds, but I prefer a 20-second cure on my adhesive just to ensure that I got the light to the absolute deepest part of the prep.
All right. And do you have time for one or two more?
Sure, go for it.
All right. What is the name of the composite warmer that you were using?
Okay, so the composite warmer I use is a company called Adent, Addent, and it's called the Calcet, Calcet composite warmer. Yeah, look them up. Check it out.
Perfect. And our last question asks, how do you control gingival bleeding if you didn't have a diode laser?
A diode laser, okay.
Yeah.
If you don't own a diode laser and you've got bleeding gingivally, I think the next best thing is to apply a ferric sulfate compound. Usually about a 20% does the job for most bleeding. You could go all the way up to a 35% if you have a real heavy bleeder. If you have very light bleeding, then scrubbing with, say, an aluminum chloride would be the next thing to do. So for those heavy bleeders, start with a higher concentration ferric sulfate.
All right. And I think that, we have one last question that just came in. Do you ever use a sandwich technique with the glass ionomer?
I do not. And in fact, when you look at the evidence on that, there's a number of articles that say in an acidic environment, which most caries is, the glass ionomers tend to wash out. Now, with that said, I never say never. If I'm down on root structure in a geriatric patient who's demonstrated no ability to keep their mouth clean, and I just simply cannot isolate or keep it dry for a composite, I will use a sandwich. But it's not my go-to. It's kind of in my back pocket, my bag of tricks when conventional won't work.
All right. Well, that wraps up our question. So thank you for taking the extra time, Dr. Geissberger.
No problem.
Appreciate it.
No problem. Yeah, we're a couple of minutes over, but I hope everybody learned something and enjoyed the program.
Absolutely. So thank you so much again, Dr. Geissberger, for the great presentation this evening. And thank you to Clinician's Choice for sponsoring this webinar. If anyone has any outstanding questions, please email us at webinars@henryschein.com. To view and register for upcoming webinars, go to henryscheindental.com/webinars. And as a thank you for attending, everyone will receive the recording via email in the next week. Thank you all for joining us, and we look forward to seeing you on future webinars. Thanks again, Dr. Geissberger.
Thank you. Nice to see you again.
Have a great night.
Okay, bye now.